Good morning, everyone. My topic is raised intraocular pressure in thyroid-associated ophthalmopathy, non-responsiveness, and paradoxical association with glaucoma progression. There are no conflicts of interest or no financial interest. The causes for raised IOP in TAO patients include deposition of glycosaminoglycogens in the trabecular muscle, increased episcleral venous pressure and orbital pressure, response to steroids administered for TAO, and gaze-related restrictive myopathy. The various management options include glaucoma medications, selective laser trabeculoplasty, glaucoma filtration surgery, and treatment of TAO with steroids or orbital decompression. We aim to assess the responsiveness to glaucoma therapy in TAO with raised IOP and its association with glaucoma progression. We included the patients with TAO defined by the following criteria and having IOP greater than 21 millimeter of mercury. We excluded patients that had other forms of glaucoma. Responders were defined in as eyes in which IOP normalized after glaucoma medication and laser trabeculoplasty. Non-responders were eyes in which IOP was not controlled with maximum tolerable glaucoma medication and required surgery for IOP control. We assessed the progression in patients which had a minimum of 2-year follow-up based on the vertical cup disc ratio and visual field defect and labeled them as progressor. 42 eyes of 21 patients were enrolled. The mean age of the participants were 43.8 years. They had similar sex ratio and median duration of follow-up was 30 months and the baseline intraocular pressure was 28.1 millimeter of mercury. 30 eyes had ocular hypertension and 12 eyes had glaucomatous optic neuropathy. 15 eyes were responders and 23 eyes were non-responders. This shows the management of non-responders. Among 3 eyes which underwent glaucoma filtration surgery showed poor response. Out of the 8 eyes which underwent orbital decompression, 75% had a good IOP reduction. 4 eyes with IOP less than 25 millimeter of mercury, no glaucomatous cupping or visual field defect were just observed for progression without glaucoma medications. When comparing the responders versus non-responders had higher male ratio, higher amount of patient in non-euthyroid state, higher baseline intraocular pressure, and higher number of eyes with proptosis. 14 eyes of 7 patients which had less than 2 years follow-up were excluded from progression analysis. 25% of the eyes showed glaucoma progression. 20 eyes had paradoxical association of IOP with glaucoma. That is, 50% did not show progression with high IOP over a median follow-up of 36 months, and 21% of the eyes glaucoma progressed despite adequate IOP control. Therefore, intraorbital pressure and episcleral venous pressure is more important than assessing the IOP. Venous outflow pressure is an indirect estimation of intraorbital pressure. Hartman et al. Reported that the difference between BOP and IOP should be less than 5 millimeter of mercury to maintain the optic disc perfusion. If the IOP is reduced very much, so that the BOP difference between BOP and IOP grows more than 5 millimeter of mercury, then the optic disc perfusion is compromised and it can lead to worsening and development of scotoma. So even if IOP is high, but the difference between BOP is less than 5 millimeter of mercury, IOP lowering may not be required. Since the primary pathology of TAO is raised intraorbital pressure, raised IOP is often refractory to management. Risk factor for poor response to glaucoma therapy include male gender, higher baseline IOP, uncontrolled thyroid state, presence of proptosis. If indicated, addressing the elevated episcleral venous pressure by orbital decompression should be considered before planning for any glaucoma surgery. This is a protocol followed in our center. When a TAO patient with raised IOP comes, we start with safely tolerable glaucoma medication. There is no baseline glaucomatous optic neuropathy. We just follow up for the progression. And if there is a progression or a baseline glaucomatous optic neuropathy, treatment of TAO might be considered with medication or orbital decompression, and we might start with, we might need glaucoma surgery. Therefore, we conclude that there is a high incidence of non-responsiveness to glaucoma therapy in TAO. Despite high incidence of therapeutic non-responders in patients with raised TAO patient with raised IOP, optic disc progression is rare. Maintaining the optic disc perfusion is more important than reducing the IOP for preventing progression. Stringent IOP reduction should only be considered when the progression is documented with high IOP. Thank you.
Thank you, Dr. Mahalingam. Could you give me your free paper number, please?
Free paper number is FP22.
Sorry, 22.
FP2262.
2262. Okay. Thank you so much. And other judges, sir, please, Dr. Shakeen Singh and Dr. Parihar, sir, you have any questions to ask?
Yeah, I asked questions yesterday only. No more question now. Thank you.
And Dr. Shakeen Singh?
Same here.
So I'll ask one question. Do you routinely do this venous flow meter or venous pressure, whatever you said, or epicellular measurement, epicellular pressure measurement in these cases?
No, sir. We don't do venous outflow pressure measurement. We need a modified ophthalmodynamic for measurement. So we devised a protocol just to, this is a protocol in which we assess the progression, and according to progression, we'll modify the medication.
So this is basically a concept that this flow meter should be measured.
Yes, sir.
You have not actually done it, no?
Yes, sir. Hartman et al. Have done it and they have explained it, sir.
Okay. Right. Thank you.